So I'm going to walk through a set of slides that sort of describe a bit about what we've been doing in Mersey Care for the past, probably for the past 9 years, but in earnest, probably the past 6 years. And I'm putting quite a lot of personal reflection into this. And I'm going to try and draw on maybe 6 key points that I think might be critical to make sure that your strategy isn't one of those things that you use 2 years later to sort of prop up the wobbly leg on the coffee table. I've written many strategies that's what I've used them for, but I think it's to reflect on what turns strategy from interesting rhetoric into something that can be absolutely delivered. Can I have the next slide, please? The slide shows it's our journey since 2015. It was quite a bit that predates that, but I just wanted to focus on this bit because I think it describes a certain sort of form of innovation. It's certainly complex and it's been very demanding, but it is a representation of our board's very deliberate strategic objective to grow Mersey Care by acquisition. In other words, by acquiring other organisations. But other organizations with which we had a sort of very strong service-based relationship with, and underpinning that was our sort of one of our core other strategic objectives was to begin to think about becoming a scalable platform for population health management. And population health management is writ large through the white paper published in 2021. It was much less obvious in 2015. But I suppose that's the first point is, I think strategy is about not trying to predict the future, but trying to give yourself a set of reasonable options for the future so that as you move forward with your plan, you can be generally right rather than adhere strictly to everything in the plan, and as often as not be specifically wrong. So that's the sort of context. So by the time June of this year comes, from 2015 to June of 2021, the trust will have trebled in size, which is a pretty significant achievement, actually. Next slide, please. Sort of is a critical one. If you just click next again, Lauren. This talks about really a foundational piece that we have done in this. And so I suppose point one is on sustaining your approach. It's about as strong a focus, maybe even a stronger focus on organizational health than on just organizational performance. We've all grown up in an NHS that is very driven to deliver targets and outputs, and we become intensely performance driven. Our approach has been to spend time in organizational health. We define organizational health largely around the McKinsey 9, but there are other ways to think about this. But phase one is to think about direction, leadership, and particularly culture and climate. That third bit is really, really critical for us. I mean, lots of people do direction. Lots of people invest heavily in leadership, but leadership has to have a certain set of conditions for it to align appropriately with everything we're trying to do corporately around strategy, with the workforce itself, and then this other feature of the culture of the organization. Next slide, please, or next click, please. We also then focused on stuff that will be very familiar, accountability, how we get our processes done through coordination and control, the capabilities in the organization, and motivation, because these are all about the quality of execution. So, there is little point, honestly, in having a strategy if you're not able to deliver it. And actually, I think sometimes we write very ambitious strategies for organizations and then put our staff in stressful places trying to deliver those strategies without providing the sort of necessary components for quality execution. And then another click, Lauren, gets us to those other bits that are critical in this, the innovation and learning component, very, very relevant to today, but very difficult to do without the other component factors in there. And of course, external orientation. which is a sort of capacity to renew, relevance to your stakeholders. For us, we've used external orientation, very much about a quality assurance component. And of course, the center point in all of this is leadership. So everything we do reverts back to and references this particular approach. Next slide, please. Which starts to describe, on the right-hand side, you'll see what we call our strategic wheel, titled 2021. The first one of those, I think we produced in probably 2013, and it's kept that general format: our services, people, future, and resources. And the middle bit, we always refresh a little bit, but empowered service users, carers, and teams has been central from day one, and the notion of perfect care has been central from day one. And I'll touch on the perfect care bit in a moment. But the pieces of the pie, the slices of the pie, some of those are the same from 2013. And some of them are totally different because we finished some bits of work and then we introduced new bits. But we focus pretty hard on strategy that is relevant and dynamic. You know, in a sense, strategy is a sort of form of organized storytelling. And I think I saw a sketch from earlier today where somebody used the quote, "If you don't know where you're going, then you're not likely to get there." And it's therefore really important to paint some sense of direction. But also, I think, to start to engage staff in a way, I think, that makes sense of their world. And I would say this is particularly true for clinical staff. So you see the other little circle on the side, which we've used again since about 2013. Quality without efficiency is unsustainable, and efficiency without quality is unthinkable. And you can see, of course, our key challenge has been to improve quality while we safely reduce costs and cope with increasing demand. Nothing unusual about that in an NHS provider, I think. But the tendency is to occupy one or other extremes. Either we just do quality and don't worry about efficiency. And in our new system-led, ICS-driven world, that's not going to be possible. And then efficiency without quality is just unthinkable. And I don't think anybody will fight me over that one. Next slide, please, Lauren. So we've thought pretty hard about some of the components of how we begin to achieve breakthroughs in safety and quality. And you'll see as this presentation goes on, I also start to talk not just about safety, but psychological safety, because actually one has to precede the other. There are many components to how you might do this stuff. I mean, we've got 5 buckets that we've thought about a lot. I think often people start with accountability. Many organizations, in terms of delivering their strategy, revert very quickly to accountability. And by that, I mean, it goes into everybody's PDP, everybody has a target. And when those really difficult things to do that involve changing culture don't happen, we have an accountability conversation. And often that accountability conversation can be, well, actually, maybe we could just try a little bit harder. If only you could just. And I think that has got very damaging consequences for culture. So we've thought about the 2 ends of this and then started to work our way in. One on outcomes, we probably deliberately started here. So where are we now? What do we want to achieve? And what do the people who use our services want us to do for them? What really matters to them? And then the other bit we've thought about is to improvement has to change mindsets for culture to be sustainable. So in a way, not every element of the organizational health framework is necessarily equal. And there's lots of evidence out there about the bits of these things that you can choose to drive in a particular direction. But you have to start, I think you have to have a view as to where you want to start the journey, and you need to understand the consequences of where you start your journey. I'm going to focus a little bit on the mindset matters piece on the next slide. Because I think my point would be about sustainable culture. Ignore mindsets at your peril. if you think about existing outcomes and going down round this U-shaped bend here to get the desired outcomes, often we start at the level of intent. So the white paper is a level of intent. It's got existing outcomes in the system. The white paper describes a new set of outcomes, and the policy is all about intent. And there are people politically who think, of course, because they've written it down, it should happen. And that's a sort of massive issue, I think, in terms of the delivery of strategy. The paper itself doesn't create the change. And what we're most familiar with is thinking that those existing outcomes happen because of an existing set of work practices. And what we need to do is change the behavior of people who do those practices and convert them into new working practices. And of course, there's some truth in some of that. But our hypothesis has been, and I think proves to be increasingly reliable, is that you need to understand the existing mindsets, because that's what drives people's engagement with existing work practices. That's what encourages them to do workarounds and all of those sorts of things. And if you want to change existing mindsets to desired mindsets, that has to operate at the level of cognition. And that's, for me, the point where we say, if you don't have psychological safety in this, if you don't understand what inhibits a change in mindset or drives a particular mindset, then you're not likely to get round this particular corner. And my hypothesis is you probably won't deliver your strategy on that basis. So, ignore mindsets, ignore psychological safety at your peril. You may deliver something, but I don't think it will. I don't think it's a route to sustainability. Next slide, please. So we've talked a little bit about very little bit about perfect care, but when we sat down with lots of service users in our organization and we asked them what really mattered, they talked about lots of things, the things you would expect, but somewhere in all of it, when you distilled out what people wanted, they wanted the services to be safe, they wanted them to be reliable and effective, and actually they wanted us to be not just really good at one thing, but good at lots of things. So we distilled this and we decided to call it perfect care. I mean, it's an idea we borrowed from IHI, pursuing perfect care. It's a controversial notion. Not everybody thinks perfect care is possible, but I was really interested in Juliet's "Where would you like to go on holidays?" So for those of you who chose more exotic destinations where you can't drive or sail, I'm presuming you're going to go by plane. And when you get on that plane, you fully anticipate that you're going to land at the other side. So actually, in real life, in everyday life, we've got absolute regard for perfect processes. Otherwise, we'd probably never get in a plane again. So why do we apply that thinking to healthcare? So we've developed a zero-based set of approaches. These are not targets. There are no targets associated with these, no trajectories, no timescales. We have developed them to find a way to galvanize motivation and purpose, particularly in our clinical staff, with our core mission to deliver perfect care. So really very important as a means. So when we started to talk about some of these issues to our staff, they said, actually, it's really interesting, but that connects me with, the young community nurse, the young community psychiatric nurse 30 years ago who actually wanted to make sure that it was okay for people who were incredibly vulnerable. But instead, we got officialized during the years and we fill in paper and we deliver targets and we do all of these things. But actually, this has set my soul alight again. And that's really critical, I think, if you're going to engage the whole body of your organization, the front line in delivering on strategy. So, so far so good. Now I'm going to tell you a story of reality. So next slide is what happens in the context and challenge of focusing on strategy without a focus on either safety culture, and let me introduce here psychological safety culture. And this was Mersey Care pre-2016 staff survey results with lots of concerns about fairness and reporting of incidents. significant volume of disciplinary cases, really significant volume, with 50% of disciplinary investigations resulting in no case to answer. So terribly lengthy suspensions that are damaging for staff and for services. Policy and process improvements were in place, but they were desperately rules-based. It was like an organization almost run by algorithm. Staff engagement sessions told the trust the overwhelming obstacle to staff transparency in the delivery of care was their fear of what happened if something goes wrong in their eyes. And if you don't have transparency in terms of your learning, you don't really have learning. You have people with their back against the wall offering you what they're prepared to offer you, but not necessarily getting to where we need to be. Staff told us that the trust's processes in HR and patient safety terms were retributively focused. By that we mean who did something wrong? What are the consequences for doing that wrong? What additional rules do we need to write? Because the first rules we wrote weren't good enough. And effectively, let's sublimate this to people are the problem. And if only people would do things differently, we could deliver our strategy. So the retributive emphasis was in our language. So investigations, hearing, allegations, disciplinary actions, tribunals, mistrust. So that's the language of retributional, coronial, legalistic system. So we use that language, and then we expect our staff to have no fear, have no concerns for their future, their professional reputation, their income, and they should just disclose everything and all will be well. And in reality, we discovered very little or impaired learning, and therefore, if you don't learn, you don't prevent. And bless us, we've seen so many cycles of lack of learning and repetitive avoidable harm to patients in the NHS that I don't think we're unique in any respect in managing that. So next slide, please. This is what it looks like when your staff lack psychological safety and you ask them a question. What happens when something goes wrong? So we ask 400, independently 400 of our senior clinicians in the organisation that very question. And what they told us was a seminal moment. It was a tipping point. It was seismic for the board of this organization, with 50%, the big bright, the blue part of the donut, basically saying fear, shame, blame, consequences of dismissal, and all of those things. Now, I'll put the writer in up front here. I don't think me, my team, or my board are those sorts of people. That, you know, we're setting out to do that stuff. But actually, you know, we use a phrase now, work as you imagine it, strategy as you imagine it, is different to work as it's done and strategy as it's delivered on the ground. And there's often a big hierarchical gap between those who imagine what it's like to do the work because they've instructed it and they've written it and they've preordained it, and actually the people on the ground who receive it. And then when things didn't go well, they perceived lack of support or trust, and even the organization itself would be adversarial. Even though lots of people said, by the way, it's not us, it's your systems. But, you know, we don't want to listen to stuff like that sometimes. And anyway, the rest of it is there. But it's a very clear-cut issue of lack of psychological safety. And to show you how vague sometimes our world is, how coincidental things can be, another organization somewhere else using the same team did exactly the same piece of work, and it actually, believe it or not, looked worse than that slide. And I didn't think you could look worse than that slide. And the board of that organization said, oh, it's just perception, it's not real. And of course, psychological safety is a real thing, but it is driven so dramatically by perception. So next slide, last few slides will deliver us into what we did about this. We'd heard about Just Culture, and if you haven't read the book in the top left-hand corner by Sidney Dekker, it's a classic. And there are many definitions of just cultures. There are many views on this. So we're quite specific that our definition of a just culture accepts nobody's account as true or right, and others, therefore, by default, wrong. By the way, that includes me as the accountable officer. So I've no right to assume my view is the right one. But it accepts the value of multiple perspectives and uses those multiple perspectives to encourage both accountability and learning. Somebody asked for a no blame culture earlier. Don't think you can have a no blame culture. I know exactly what you mean, and we started with a no blame culture, but people very quickly interpret that as anything goes. And actually, a just culture is a very, very delicate titration between accountability and learning. I'll talk a little bit more about that in a second. But in the next slide, our version of just culture is a restorative one rather than a retributional one. Retribution focuses on which rule is broken, who did it, how bad is the breach, and basically how hard do we need to beat them so that they're appropriately contrite and punished for that purpose. And that's not really the system that we are building, but it might be a system that you've probably experienced at some point in time. But it's counterproductive. It inhibits learning. It inhibits reflection in teams. It doesn't involve any humanity. It lacks compassion, forgiveness, understanding. And we have to build up an approach that is based on restoration and healing, which asks, who is hurt? What are their needs? Whose obligation is it to meet that need? And how do we involve the whole community? Now, the whole community could be the whole community of a trust. It could be a true community. It could be the people you serve. It could be a community of particular clinicians. It could be a patient and a member of staff as a micro community. And the goals are about moral engagement, emotional healing, reintegration of the practitioner. So the practitioner is able to learn as an individual. Therefore, if multiple individuals learn, there's organizational learning. If we do that really, really well, then the last time it happened can be the last time it happened in truth. So we can move towards a preventative set of measures. Next slide, please. So we worked then to think about how do you make this real rather than rhetorical. So perfect care, given that we were going to ask people to do big, hairy, audacious things, it's quite clear in our system nobody would take a risk. People were worried that if they stepped over the line, even though they saw the logic in it, but if they stepped over the line to do some change and that change goes wrong, it involves punishment. So we had to develop a non-punitive culture where we can flourish in response to when things don't work out as planned, and where our first response is compassion. It balances personal responsibility. Doesn't, you know, if you do something that's illegal, for example, you are responsible and you will face full professional accountability in our organization. But actually, most things that happen aren't that black and white. They fall in the gray space. It's not blame-free or being tolerant of absolutely anything. It is this careful balance of accountability and learning. And by accountability, we mean it's prospective accountability rather than a retrospective bias. So it's forward-looking accountability. How do we learn from what happened? And how do we incorporate that learning to reduce the risk of it happening again? Rather than a retrospective one, which is about saying, so who do we now hold account for that, rather than who gives their account in a prospective system. And that retrospective bias is a huge thing, because when you become prospective, you ask what and how, but not who, because truth is a bad system will always, always, always beat a good person. And if you think about how often in a retrospective system, we often start, well, okay, who was at this incident? As if that's somehow going to magically tell us something. Next click, please. So a just culture from Decker and from us now, I really want to talk just about the last two bits here. It allows the organization to invest in improvements that have a safety dividend rather than deflecting them into legal defense and liability protection. So one of the things that happens is if you've got a retrospective blamish culture, you're not transparent, and actually people become in opposition to each other very quickly. That might be patients, it might be staff who are in opposition to the organization. But that in the end involves escalating legal fees. And what we want to do is not spend money on lawyers. We want to take that, create a prospective, just approach, a restorative approach, and the money we would have spent on the lawyers, let's call it a safety dividend, and reinvest it back into our people. And what we can simultaneously do is satisfy the demand for accountability and the need to learn. Because if we get the accountability approach wrong, nobody learns. Next slide, please. So the next slide gives you a little bit of data about what we've done so that it's not all just talk. When we started this, our staff said to us, look, this sounds awfully like a chief executive talking SH1T, if I can describe that to you. And they said, look, if you really meant this, we would change our retributive approach. And we've got a retributive approach because look at our investigations and suspensions numbers, they're really high. And we'd see those numbers change if you introduce restorative practice. So you can read the graph. I don't have to describe the graph to you, but investigations have decreased by 85% since between 14 and 19, and suspensions by 95%. We're evaluating the next 2 years, and those numbers just go lower. But bear in mind, the very first slide I showed you about our acquisition history, we did this at the same time that the trust increased its workforce by 135%. So this is a doable and a completely transferable approach. Next slide, please. And I'm close to the end. So what have we achieved here? First click is where I think we were, who's responsible, be punitive and adversarial, and seek legal sanctions in many instances. So next click, we've moved to a much more psychologically orientated place where candor, reflection, and debrief is really the core of our learning. And that takes us to forward-looking accountability. Then the bit that's going to come in the middle now, the click, is when you ask what is responsible, you find out really interesting things. So the blue things are what we would describe as professionally accountable issues, and the orange box is the stuff that's actually organizational accountability. And the importance of that is two things. In the old world, in a retributive world, nearly everything goes in the blue box, and the professionals feel beaten up. And everybody, you know, who's accountable, executives and all of those people sit and look at this and wonder what to do with it. In this sort of approach, the orange box becomes the organizational accountability. And I've got another title than chief executive, which is accountable officer. And that orange box makes me feel very accountable for everything that goes in the organization. So I'm either, and my team are part of the solution, or we're part of the problem. This makes us part of the solution. Next slide, please. And the next slide, please. So in summary terms, next one, please. I think, you know, we focused on concept into practice, and this is, for me, really important if you want sustainable strategy. You've got a campaign in rhetoric, that's fine. You can campaign in rhetoric to your heart's content, but you've got to govern in prose. So you have to turn the rhetoric into some form of reality. That for us was why when we look at our big, hairy, audacious goals, we've 30% fewer people down by suicide. We've really changed the profile of pressure ulcers and medication errors in the organization. That's because when we took the outcomes and the mindset piece and worked really hard on those, that's when we started to do the capability and the practice improvement and all of those sorts of things. So you have to underpin this with operational excellence and support. But we have to hold judgments and instead we've got to ask ourselves why people behave in the way they do. In my long career in the NHS, I've met very, very few people who don't want to do something great. So people don't come to work to do bad things, if we want to paraphrase it that way. We must see transparency and openness as allies. not as enemies. If we can't be transparent, we can't learn. And we need a culture that allows the boss to hear bad news. We've co-produced everything I've talked about with our staff side colleagues and with a great many patients and service users in the process. We're now moving from learning from the things that didn't work out well to learning from the good things we do every day as well. And that brings joy at work for our staff. Does it cost a load? We've spent very little on this. You need to understand the distinction between resources and resourcefulness. The latter takes you a very long way, especially when you fire people's engines up around this sort of stuff. But to do that, you need to see people as a solution and not as a problem. And we need to ditch all of this heroic leadership stuff and start to share some of our vulnerabilities. There's real strength in that sort of sharing. And then last slide just is a summary of where we might be and where we want to go. So the bottom line is, the top line is a world with compliance and CQC and regulation and telling you what to do, and you must get stuff done. It's by tipping your hat to the people in power. If it all goes wrong, it's retributive. And occasionally the brilliant things that happen are often acts of individual genius. We want to unleash curiosity. We want it to be all about involvement, about participation, the strength and power of diversity, of every single element of diversity we can engage, that allows us to be restorative and actually builds on what we've discovered during COVID, that actually collective wisdom is much more powerful than individual genius. So that's where I'm going to leave it. And thanks very much for taking time to listen to me. Thank you.